Greetings and a warm welcome to our monthly webinar, brought to you by the Institute of Public Health. I am Mariam Al-Makhmari, an alumni of IPH from UAE University. The Institute of Public Health at the College of Medicine and Health Science is committed to providing a platform for knowledge exchange, networking, and professional development through this interactive session. This season is a part of global initiative, This is a Public Health, dedicated to highlighting critical public health matters. We are honored to have affiliation with ASFER, the Association of Schools of Public Health in the European region. Before we proceed, a few housekeeping notes. Feel free to engage by asking questions throughout the webinar. Simply click on the Q&A option at the bottom center of your screen. This webinar is being recorded and will be available on our YouTube channel, Institute of Public Health, alongside past webinars. I'm pleased to announce that this webinar is accredited by UAEU as 1CME Category 1. Following this session, you will find a link in the chat to evaluate the webinar. Your feedback is invaluable, and upon completion of the evaluation, you will receive your CME certificate of participation. Now, it's with great pleasure that I introduce today's esteemed speaker, Dr. Paul Gately is CEO of MoreLife and a visiting professor of exercise and obesity at Leeds Beckett University. He's also a visiting professor in the Department of Surgery and Cancer at Imperial College London. Dr. Paul is the principal investigator on Public Health England's whole systems approach to obesity, and he is the co-director of the Obesity Institute at Leeds Beckett University. His primary research interest is adult and childhood obesity treatment strategies, but he has a focus on the use of systems approach to tackle the wider determinants of obesity. Dr. Paul is also the interim CEO of Obesity UK, a member-led charity. The title of his presentation is Child and Adult Obesity Treatment Strategies. Dr. Paul, the virtual floor is yours.
Thank you so much for that kind introduction. And thank you also for sharing those my sort of role and activities for me. That's really helpful because I think it sets the scene for really what my work has been trying to do for some time, which is really align treatment and practice with evidence and science that evolves and moves the agenda of obesity forward. And within all of those roles, the lived experience of people living with obesity, either children and adults or families, has been a critical feature. So I guess to put it into context, and firstly to say is World Obesity provides some fantastic resources that you should be able to draw on. So I've just drawn down data from World Obesity on the UAE, and what we can really see is high levels of obesity that people won't be surprised to see, and we can see increasing levels as well. The evidence on the UAE's ability to meet the UN adult obesity targets is, as it outlines here, still very poor, and we've seen a sort of rapid growth, and that's unsurprisingly also having an impact on wider NCDs. So there is serious issues.
Prof, Paul, if you don't mind, but the screens are the slides are not moving, so
They're
maybe
not
if you can
moving. Oh
no.
Oh,
So maybe you need to put it. It's okay. So can you put it on the play mode? Yes, perfect. And make it as plays.
Is that no?
So,
is that
no, still still not. So maybe I'll click it. I'll click on that slideshow again.
Yeah.
Because yep, again, yes.
Oh, I see. Click on screen. Is that moving them forward?
Now we can see the slides, but unfortunately we cannot see it in full screen. But if you have an issue, so it's fine. We can continue with that. Thank you so much.
Oh, sorry about that. Okay, so in the context of then trying to explore the drivers of obesity, again, drawing from the World Obesity information, I've just drawn some comparisons of statistical neighbours or neighbours to the UAE, and trying to compare and contrast some of what we know are critical drivers for obesity. So fast food consumption, which the UAE is at the higher end of the spectrum. Mental health, and I describe mental health as a driver, but also a consequence of obesity. So we know from the evidence there's a bi-directional relationship. And then insufficient physical activity, again, across neighbours, across the Middle East. UAE appears, based on this data, to have some of the highest levels of insufficient physical activity. The other thing, an area that I don't think gets enough research, is about sleep. And lucky to have some data from some of your colleagues in the UAE looking at sleep deprivation on stress levels. And what we know from the evidence really clearly is that less than 7 hours a night sleep doubles the risk of obesity. And this is just some data from the UAE demonstrating that young adults actually only about 45% of them meet that criteria. And in middle-aged adults, that drops down to 30% are meeting the criteria. So if we know over half or nearly 2/3 of the population are getting less than 7 hours a night sleep, then we know that their risk of increasing obesity or not shifting their obesity continues to rise. So of course, I think we'd all agree that. But often sleep is not part of an intervention strategy. So I'll be surprised if you don't know the consequences, being as you do. But again, comparing to your neighbours, or many of your neighbours, we can see, your sort of higher mid-table in diabetes prevalence, raised cholesterol, you're at the higher end of the spectrum, and of course the influence on obesity on a number of cancers, and namely a very important one, breast cancer. Here the data shows again that you are toward the higher end of that spectrum as a population. And so fundamentally what we know from the evidence, that obesity has a profound impact across physical, mental and social health. And I think within the physical health and partly within the mental health, we know that is true for a number of populations, but I wasn't quite sure of the data, and I couldn't find the data on the social health impacts around the UAE. So for me, that would be a really interesting topic for colleagues or students to be interested in, is to really try and determine some of the social health impacts for populations within the UAE, because there's good evidence in a variety of places, particularly in the UK, the US, some of the European countries, but I was unable to find strong evidence around this within the UAE. So, for any of those budding PhDs, for me, that would be a really interesting place to go. And fundamentally, the economics of this are really important. And even for some of the most affluent countries, UK, US, and indeed, the UAE, at the end of the day, this is lost cost, basically. And not only is it impacting on people's lives, but it impacts on the sort of UAE PLC, if you like, or the economic strength of the UAE. And as you can see, those costs across the UAE are projected to increase. And again, I've drawn this data from World Obesity, so you can quite easily access it and use it as you all see fit. In much of my early career, we were focused a lot on the biological factors and the biological influences and the biological consequences. But actually, more recently, we've focused a lot of our treatment strategy development on mental and emotional health, because whilst we know there are biological impacts and physiological health impacts, how do we do something about that? So if we're only operating within the biological fear, then really pharmacotherapy is one of the only, or surgical interventions one of the only. Whereas actually we know that lifestyle factors are critical, but how do you get people to change behaviors? How do you engage them? How do you understand them? We have to begin to tap into the mental and emotional factors. And I guess from a contributing factor, think about children and school. We know very clearly that academic outcomes have an impact on people's life chances, and that evidence is clear across the globe. But we also know that, and this is UK and European data, that and US data, that evidence is that obesity has a big impact on children's attainment at school. And so if school is such a big stepping stone for the future life of a child, then of course we want to make sure that their educational experience is positive. And yet the data on this shows very strongly that, as well as those longer term biological consequences, some of this data in terms of school performance, educational attainment, and children describing themselves as poor students really doesn't paint a good picture. And the other evidence is really about body image and eating disorders. And we know there's an emerging literature, there's a strong literature across UK, US and Europe, and there appears to be an emerging literature and evidence base across this within the UAE as well, demonstrating similar sort of trends, although slightly different trends to what we're seeing in the UK and Europe. So again, for those budding students, for me, this is a really important area to understand, maybe what some of the cultural benefits are within the UAE that might be somewhat protective in comparison to other countries, or what some of the challenges may be for those that are at risk of disordered eating or body image dissatisfaction. Again, I think these are really promising and important. And the reason they're important is, and we're now doing a lot of work in the UK around this, is when our GPs would refer patients to us with a disordered eating, 90% of those patients would drop out within the 12-week intervention. Whereas with a program of support and around their disordered eating, about a 6 to 12-week program of pre-intervention, that changes that from a 90% dropout to a 90% completer rate in the subsequent follow-up weight management intervention. So what we know is that disordered eating has a profound impact on success on weight management programs. And if that is not addressed before the weight loss intervention, then we are wasting resource, and we are probably wasting time of our clinicians, and we are also wasting the time of the patients as well, because we've got to get that pathway, that care pathway right. And so for me, the mental and emotional health are really critical. And an emerging literature around just having purpose, and what are the values and what are individual goals. And we hear a lot in the well-being literature around young people having a future, having a purpose, and it's shaped in childhood, it's influenced by food or culture, and that element of being judged by oneself are sort of themes that emerge from this literature for people living with obesity. And the other emergent themes are this concept of longing for normality. And we've done some work around this. And what's really interesting is when talking to children, particularly children who suffer with obesity, all the time they are desperate to be normal, but treated not normally, treated as a child with obesity. And even their behaviors, what they tell us, children tell us they have to have the most perfect diet and to be exercising a lot every day to be treated normally. And what that means is that they have a weight problem, but are appearing to follow what are the stated guidelines by health professionals to achieve the goal. And so they're almost having to be what they describe as super healthy in order to have a weight problem, but live up to the expectations of those people around them. And that's quite a big, tall order to ask children and young people. So those are themes that we really need to think about in terms of our language, our tone, our goals, our messages, if we are really to help children achieve the goals that they want. And then fundamentally trying to close this loop around these are obviously not independent factors. So the physiology is not independent of psychology. And we know, as we start to hear, as we see emerging evidence about inflammatory markers, inflammatory factors within the sort of metabolic area of risk, we know that there is a strong connection between sort of stress, obesity, inflammation, depression, and so the cycle goes on. So this becomes important that we both consider the psychological as well as physical, and as I've tried to outline, the more social factors. Okay, so how do we move forward? There's the problem. And I guess most of my career is I've spent time really trying to sort of understand the context of the problem. And one of the things that's become really clear to me is there's a lot of advice, but it's very generic. And anybody who actually has a role of working with people in any clinical role will appreciate all the time that different people have different needs. And I'll give you, this is just a moment. This was some children we worked with in Doha, in Qatar. And what I've tried to do here is identify some characteristics of different children to get you to think about how hard it is to then design interventions at a group level that support children at a personal level or support them and their families. And you will all know the uniqueness of different families and therefore the struggles of different families. And so child number one, caring family, food's at the center of their family. There's limited boundaries around food. They're not very active. The pupil is very well liked at school. And so, we were talking to mum, and mum was saying, well, he's really well liked at school, and therefore, why is there a problem? And of course that there is a truth in that. It's well liked, and so that appears to show that mindset is liked, so he's okay. But from a health perspective, we would know that they wouldn't be. Child number two struggles with autism, aversion to new tastes and textures, and struggles with their physical education and avoids sport at any opportunity, and is teased at school and feels isolated and sad. And already you can start to see two very different cases requiring two very different personalized interventions. And then child number three, busy parents, and they are left at home by themselves. They are able to order in food. They enjoy being on their sort of Xbox and watching TV and reading. And the family are confused by the weight gain. It's a busy household, as they described it. So all of those demonstrate the different contexts that each of those families exist in. And of course, the sort of goal of weight management to date has been eat less and exercise more. And indeed, even our pharmacotherapy interventions and our surgical interventions are food restrictive. But actually, if we are to think about how do we design long-term interventions that are effective, then at the heart of any intervention is of course strong processes. As we all know, strong clinical processes that are safe, that are effective, that are recognizing the importance of caring for those patients, that are responsive to those patient needs, and that are well led within a clinical environment. And these will all be typical normal practices for all of you that are involved in clinical care or management. Now, when you start to think about those three case studies, then begin to think, what will the referral process be like? How do we communicate from if you like, a primary care worker or school nurse or a local community nurse, or indeed a parent saying, my child's got a problem? What's the mechanism for referral? How do we then make sure that those children, or indeed adults, are triaged in the right way? So the triage process in terms of determining their physical health, their mental health, their social variables which are influencing, and how do we make sure that we move them into the right intervention in the right community for them? How do we then think about that initiation? Is it the right time for the individual? I'm sure many of you will have heard of readiness to change. And, you know, how do we initiate that conversation? So a conversation with an adult that has autonomy and agency may be very different to a child or someone with a learning disability. So that initiation process may seem simple, that you need to lose weight, but actually the complexity of the individual and their circumstances. Then we move into thinking about their intervention. How is that intervention designed? Where is it? Is it digital? Is it face-to-face? Does it require an endocrinologist? Does it require a psychologist? Does it require a community health worker? What's the level of intervention we need to design? And therefore, we all know that what's critical about weight loss is the weight loss phase is important, but the maintenance of weight loss is the critical feature that will maintain the health of someone for the future. So that transition from the intervention phase to the maintenance phase is still an area of weakness in the world of obesity. And even with the wonderful new GLP-1 weight loss medications that have emerged, we also know that when people stop taking the GLP-1s, their weight comes back on. And then finally, what's the end of the journey for both the individual or for both the clinician? What is the stop point and where do they go and how do we help support that? And of course, those things will all be familiar to you as colleagues. That process will be familiar. But we also need to then think about what are the wider influences on all of those variables. So I've touched on some of them, sort of disability. Does that influence the pathway, the family environment, the mobility of those individuals? Politics are always at play. Age, sleep patterns, we've already identified that, you know, across the UAE, in our adult population, nearly 2/3 of the population don't sleep enough. So that will have a profound impact. And if we don't include sleep in the intervention approach and just focus on diet and exercise, we are missing a fundamental component of any successful intervention because we know how influential sleep is. And what I would argue, and I'd be very surprised if we did an audit of most interventions available across Europe, the UK, the US, and the Middle East. Sleep will be a small component of that intervention design. So again, just trying to get you all as colleagues to think about what may or may not be the essential components of successful interventions. I just want you to sort of walk you through some work that we did in Qatar because it was really enlightening for us. The first thing to say was it was a real collaboration that, you know, as in public health, I think we work very well with partners and collaborators, and that was what we did across this intervention program. It was funded by the QNRF, so the Qatar National Research Fund, and we had a variety of partners there, from the public systems to the academic systems to the local health systems as well. All of that was incredibly valuable in how we sort of designed and developed, and it was co-developed and co-produced with our colleagues at the universities, but also a number of these were students, master's students, PhD students who did this work as part of a program of overall development. And the program we designed was a 2-week camp during the sort of January holiday, followed by a 2-week break, and then a 16-week community program with activities across the whole of Doha. And we had cohorts of over 100 children moving through this over a 5-year period. And we, you know, a key element of this was to test the approach, understand the local context, and we got some really interesting insights. And also because across Qatar at the time there was significant investment into its computing and internet, into its software infrastructure and digital infrastructure, particularly around health, we were working on the development of some digital tools as well. So that was a really exciting program, and we were engaging those young people in a variety of different activities. And we got some really good outcomes in the 2-week intervention. Then they had the break, and then we moved to that sort of longer term intervention, the community intervention over 16 weeks. And we saw continued weight loss in those children and young people. We got some fantastic feedback from parents that we worked with, and here's a comment from Mohammed's mother on, you know, the positivity, what he learned over the course of the program. And then Fatima, mother of Fatima, who explained about how she'd sort of learned about portion sizes. Key thing is fun, you know, and in my early career, I used to find that a lot of interventions around weight management for children and adults were painful and miserable, and they're not engaging components to any intervention program. And we shared that. We developed resources in Arabic and training plans for all of our staff in English and Arabic, and for the families, all the manuals were developed in Arabic. And then we published a variety of papers on this program that you'll be able to find. But I guess thinking about, that's all well and good working within a personalized family environment. What we can't ignore is the reality of the environment we live in. And whilst it would be ideal if our colleagues in Dubai were commuting to work using active transport, or eating a real healthy diet and rich diet of typical food across the sort of Middle East. But unfortunately, those images on the left or the right of your screen, left of my screen, unfortunately, those are not the images of reality. More so, the images on the right of the Dubai food court and the streets, many of the streets in Abu Dhabi, Dubai, and a variety of other cities across UAE, and the sort of proliferation of, you know, food delivery. And then the bottom slide is relatively is a bit harder to see, but what it shows that in is the daily steps across different countries. And what you can see across that Middle East region is much lower physical activity levels, and of course climate will play an important part in that. But obviously the images of the food court and the Deliveroo and the streets lined with food outlets is of course that unhealthy environment. That all well and good, we can help children understand and adults understand how to live a healthier lifestyle, but if they are still existing within an unhealthy environment, then it becomes more problematic. So whilst yes, of course we would like active travel and a healthy diet, the reality is somewhere different. So the question is, how do we change that alongside? And you know, this work's nearly 20 years on now, and this was a report by the UK government, a foresight report, which looks 50 years into the future and talks about what causes obesity and how do we do something about it. And this is quite, for those who've been involved in public health and particularly obesity, this is quite a familiar map, but really what it shows at the heart of it is the energy balance equation. And then it identifies about 125 different variables which we know influence obesity. But those different variables are connected by over 300 different factors that are driving obesity. And so this is a system map. In addition to that, what you can see in the coloured dotted lines is the individual physiology, the food environment, food consumption, social psychology, the influence of marketing and communication, the culture that we all exist in, and different cultures that we exist within and are from, all have influences on those individual level influences. So we begin to build a picture that it's not so simple as energy in, energy out. So considering that, there's been work over the last 20 years that's tried to think about the sort of determinants of health at variable levels. From that, I've talked an example of an individual level, but then thinking about that sort of the built environment and the local food environment, or the school environment, or the community environment, or the travel or transport environment. All of these are influential environments on individuals. And of course, within the heart, we've got their age, their gender, their hereditable factors as well. So we've got to now think beyond that individual and think of the influences on them and with them. And unfortunately, this is where we find ourselves. I would argue that we have a system that is not integrated, a system of strengths from universities to private sector to health sector to transport sector, But the white in the middle of this, the lack of connection between those different important system parts is weak. And so why would we be surprised that rates of obesity continue to rise? And maybe what we need to think about is move to a vision where we think about, okay, so the wider system of education, society, government, industry. What does industry mean? Taking what we've been working on for the last 10, 15 years as a program of whole systems approaches to obesity, and thinking about how does parts of the system work in unison rather than work independently, from our sports or our transport and planning, from our food companies, health sector, media, private sector, civil society, built environment, universities, parents and children. And of course, across the UAE, those different systems will be different than the UK systems. There'll be some similarities, obviously, public health, university, business, public sector, but there are obviously differences within those variables as well. But the fundamental point is, how do we bring together all those different actors to work in a unified way to tackle the problem collectively, so that the personalized interventions that are as important as the system interventions can work in unison? And so I'm just going to sort of share, so for me, it's this building of this picture from that, as I alluded to, personalized intervention, thinking about the individual right across to the way the system works. And we can't do, it's not a pick and mix, it's not one or the other. And this is where I think we're struggling in public health at the moment, because individual voices will try and change the food system independent of individual, or those clinicians that are really positive to look after their patients and thinking at an individual level, not necessarily operating at a system level. And we've got to try to find ways of doing this. And there aren't that many good examples, it's fair to say. So just to finish, I was asked by Public Health England to develop a program of work with our local government. So the UK split up into over 300 local government entities, and we were tasked with the job of designing a way that those individual government agencies or local agencies could design an intervention, but then collectively, under the guide of Public Health England, could find a way forward. And we developed a program of work, and there's a toolkit, it's downloadable. There's a lot of work to do, but it's certainly downloadable, and there's a guidance document there that any of you can use and utilize within your own areas. I think some takeaway points: we've developed a process from that setup, and that information's there, building a local picture, mapping the system, think about what action could be taken, recognizing that the system changes. And I think one example is COVID. So COVID had a profound impact on our global situation. And of course, that was an impact on our health system in many, many ways. And we are still somewhat recovering from and responding to, but it demonstrates to us that the system's always changing. So where we might be going for, a 50-year plan might be redundant in 2 years because something might influence it. Now, having a plan that is responsive to that is key. Some of the key lessons that we learn, and I've had some fantastic conversation with colleagues locally in the UAE, is at the start is understanding and taking an audit of who are the stakeholders, who are the people that are most vested interests, who are the most people that are interested in moving this agenda forward, who have resources, who can enable the system or disable the system. Understanding stakeholders is really, really critical. Understanding data is really, really critical. If we can understand our patient data, our community data, where levels of obesity are more prominent, why that is, what are the factors that are driving it, we can then start to lever that. And we know from data within the UK that we have publicly available data that can determine 80% of the factors that are contributing to obesity. So there's a lot of data available, and when we crunch those numbers, we know we can understand quite a lot about the factors driving obesity. So data is incredibly powerful. Then we have assets. What we really need to understand is, what is the strength of the system? What is, you will have a fantastic, I'm sure, public health community, and that's an asset. But where are they focusing? Where are they delivering their asset? The universities are fantastic assets. Our health systems are fantastic assets. Our private sector can be fantastic assets. But how much do we know about them? How much do we know about their goals? Are their goals the same as ours, or are they different to ours? And if they are the same as ours, why are we not working together? There's some fundamental questions that come out of the assets. And then there's an element of policy alignment. Is the national or local or regional local policy for obesity aligned? So are the local people doing the same as what the national system is encouraging them to do? And if there's not an alignment, the chances of it being successful are low. So the audit, we found in all the work that we did, was incredibly important. And some of those local agencies just jumped to action without audit. And whilst they moved very quickly to start with, what they found later on was that it wasn't working. They didn't know what to do. They came to a sort of blockage because their underlying data and underlying foundations of their plan were limited. And I showed you that map of the foresight report. We do activities with stakeholders, data, assets that help us really understand the map of the system. Because when we understand the map of the system, we begin to say, actually, if we move this lever, whatever that lever might be, school education, public health systems, hospital development, whatever it might be, we can then start to see the ripple effects of that and the benefits and the consequences. But fundamentally, a common co-produced vision with those stakeholders was always the thing that seemed to be the most successful start point for us delivering. And I guess this is not an easy challenge. No country in the world has tackled obesity at all, and are far from it. And so we now have the tools. I guess the question is which countries or which areas are going to take on the mantle of change. And you know, this picture jumps up sometimes on my Instagram, and it always makes me smile, just that demonstration of the incredible transformation of a city like Dubai, and the incredible transformation of the UAE. And so you guys, like many other countries, need to change. And it appears from this transformation of an incredible city that I was in a few weeks ago, that you have the potential to change as well. And, you know, I hope that that is a positive note to end on, to sort of what I would argue is some strong capabilities that you have as a country and as a public health system. So on that note, I'd like to thank you very much for your attention. I'm delighted to answer any questions that you might have.
Thank you, Prof. Ball, for your informative presentation. There are a few questions from the chat from the participants. One question says, is obesity related to the economic means of the family, particularly at younger ages?
So sorry, I'm not quite following the question. So I understand the economic, there is a relationship between deprivation and obesity. Yes, that's true.
Yeah.
I mean, I guess that's very true. So the data in the UK shows that very strongly, and other European countries show that very strongly. I guess what would be interesting is I'm not aware of the data in the UAE and whether that relationship between deprivation is as strong in the UAE as it is in the UK. And you know, again, if colleagues are aware of that data, I'd love to know that. But if we're not aware of that data, then that would be a fantastic research question to follow through on. Apologies if that doesn't answer the question correctly.
Yeah. Actually, there is one more question which says, what are your thoughts on healthy obesity? Could you please explain for them what does it mean, healthy obesity?
Okay, so when we look at the relationship between obesity and health outcomes, it is not a one-to-one relationship. We know that. Well, there are a number of factors that determine overall health of an individual, of course. And so I'll use a simple example. We know that if you take a male and a female, males will store their weight more around their abdomen, which is metabolically active, and therefore is more likely to cause the variety of NCDs that we would see typically associated with obesity. So fundamentally, at a gender level, you could have two people with exactly the same BMI, let's say a BMI 40, but the female is likely to have a better health profile than the male. You also could take two males, one that stores their weight around their abdomen, again, greater health risk, one male that stores their weight around their hips, lower health risk. We could take two people with a BMI of 30, let's say, one of which would be physically active every day of the week, doing a variety of physical activities, so their metabolic health will be improved, whilst their counterpart, who is not physically active, will have a poorer metabolic health. So we know that obesity increases risk, but there's a variety of independent variables which are important. So now, I guess one of the things I was trying to allude to within my presentation was around social, cultural, the relationship between obesity and disordered eating, because I think that it's certainly true for the US and the UK that the early approaches to encourage, and I use that term loosely because I think with the best of intentions, some clinicians were not sensitive to the social, psychological, and emotional needs of people, and the communication was poor. And so what that's created is weight stigma. And we know weight stigma has a profound impact on people's chances of being successful. If they feel stigmatized, they are unlikely to be successful in their weight management journey. As I was alluding to, I'm not quite sure what the data would tell us about the cultural factors within the UAE and whether that is a more prominent problem or not. So understanding those cultural factors is critically important in your vision as a public health community within your community. And I find those incredibly interesting questions, which some countries have already failed at and are really working hard. I guess some of the conversations we had in Qatar were around those pressures were not as prominent in the work that we did in Qatar, both with children and with adults. And that gave me some comfort that the weight stigma is not as prominent, but it was growing. And I guess what I would be doing, if I was involved in public health, would be trying to prevent some of the mistakes other countries have made with insensitive approaches to weight management.
That's great. That's great, Prof. There is one more interesting questions from Dr. Mohammed Abed. In your experience working with the UK, what are success stories which you can share? Obesity in young children is associated with the socio-economic conditions, and there any different approaches to address this issue comparing with the more affluent families?
So I think fundamentally there are differences, and I think the first thing that I always say is understanding the circumstances is critical, because obviously trying to provide advice that is uniform advice across two different environments is going to be ineffective. So I'll give you an example of a child that we worked with, and they lived in a deprived community, and this child, his parents were busy. They didn't come home. They left the house at 9 a.m. every morning, but didn't come home till 7 p.m. at night. This child came home from school around 3:30. So he was on his own for nearly 4 hours, and he would snack and then he would eat the family with the family. Now he was only 11 years old, and he was by himself during that period of time. That was their reality. They couldn't afford any other support. That was their circumstance. So the problem was what does he do when he comes home from school, because he's hungry and the only food available was snacks. So we did what a lot of my nutritional colleagues would say is the worst thing we could do. And we worked with the family and organized the child to have ready-made meals to put in the microwave for after school. Now, of course, that is not the best solution, okay? But it was the right solution for this family, because what happened was the child would come in, would eat his meal that he could put in the microwave safely. He would eat his meal, and then his parents would come back later and he might have a supper snack for bed. But we knew that it was dropping his calories. And so after the program, his weight had been going up for a few weeks, and then we intervened and his weight began to go back down again. And I guess it's not often the perfect example, but it's not often the perfect solution that works. It's the right solution for the family. And, contrasting that with an affluent family that may be able to have a nanny that can make sure that they're there to feed the child the right food, a small healthy snack after school, and then the family would eat together, or some physical activity they might do. There's obviously two very different contexts there that we need to be aware of. And I guess going back to that personalized intervention, we are delivering services to about 10,000 children and families, and with a very effective team of people. The resource implications are big, but not too big. So we are able to cater and support those families within a challenging National Health Service budget in the UK. So it's feasible if done in the right way, but the mechanics of it are not simple.
Well, that's very interesting. So another one more important question. It says, how can schools and communities implement sustainable, culturally appropriate intervention to promote healthy eating and physical activity among children, while also addressing the stigma and mental health challenges associated with obesity?
Okay, so we do a lot of work in this space, and part of the program we did in Qatar was around this, and we learned a lot of lessons culturally, I'd certainly say. So the process we go through, and this is years of research, years of work, and I'm going to try and distill it into 4 distinct phases, but a lot of underpinning work around this. So phase number 1 is engage with the school leaders. So the school leaders, of course, are trying to manage a number of different priorities, not just the health of the children. So first of all is to understand from them, where is health in their priority list, and answer any questions, because what we found with schools, and we found this in Doha as well as we found in the UK, that a lot of head teachers are nervous about health and wellness, and are they saying the right thing or the wrong thing? Do they have the right information? So Q&A and co-designing school interventions with the leadership team is really important. Then we do some work with training staff, so that they know what to say, what to do, when to say it, when to do it, and what the pathway of an appropriate care is for those children. Once we've addressed the school dimension, then we involve parents and young people themselves and create a school council for health, that enables us to co-produce what the school would like to do to improve their health and wellness. And we do this for 2 reasons. Most importantly, you alluded to the risk of weight stigma. Now, if children, families, parents, teachers are co-producing a solution, they will co-produce something that is sensitive, appropriate for need, rather than, whilst our health professionals and our public health professionals know exactly what to do, there is a difference between something being done to people or with people. And I guess that's a critical dimension of it, is to create the right environment. Once we've created the right environment of co-production, then we move into the phase of action. And that action phase is often based on what are the school's strengths, what do they do well, where are their weaknesses, where is the public health, local public health teams, what's their ambition, how might they support, what's the structure of sports and activities and local clubs. So what's the local community infrastructure and how can they support the school to make sure that there's pathways for healthy eating, physical activity, and a variety of other behaviours. So it's not just on the shoulders of the school, all the parents, all the community, it's collectively. So when we do that programme, we find it takes about 18 months from conception and the first kick-off meeting with the school before we have a fully functioning intervention programme being delivered.
Great, thank you so much, Prof. Paul. We're really enjoying the presentation as well as your insights, and your answers are actually triangulating the information that you have shared in the slides. And people actually are very interested. I'm worried that we cannot capture all the questions. We'll try our best. However, if we will put your email on the last slide so people can contact you and you'll be able to answer many questions. So there is another question here asking, what factors do you think contribute to the high rate of obesity in the Gulf region? I believe you alluded into that in your presentations, but people here are trying to understand whether genetic choices may have an impact. I mean, our genetic makeup, or is it lifestyle choices? So what do you think the right answer for that?
Well, that's an age-old question that I think is still going to be decades in the future for answering. And so we know that there are a variety of genetic determinants, but we also know there are a variety of social and environmental determinants as well. And I guess that's why I've tried to present the solutions as consensus building rather than singular intervention designs, because the complexity of your question shows the need for a complex approach to solving the problem. So there is no single genes that we know can contribute to obesity, with the exception of a very few people. And so therefore its gene environment interactions are critical. And indeed, the other point to note is that when we look at the scale of obesity currently, how are we going to do something about it? The genes are not going to change. The genes of our current population is not going to change. So we've still got a lot of work, and we've still got a lot of children being born into an environment that is unhealthy. So we've got 70 to 100 years of work with them, given the current environment. So I'd say we don't know. The answer is we don't know, and it will vary. But what we do know is that we can achieve weight loss. We do know that can be sustainable, not in everybody. We know surgery works. We know there's some new pharmacotherapy that really works well, but we know when people stop, they regain the weight. We know psychology works. We know exercise works. We know diet works. But what we've got to do is make sure those things are implemented for the life course to get the life course health benefits.
Yeah, that's great. And I'm happy to report here that in the UAE, we are actually, especially in the Institute of Public Health, we are hosting the first cohort study in which we are following more than 17,000 pregnant ladies and their offspring till the age of 18. So maybe with that study, we can prove the cause-effect impact of genetics into obesity. There is another important question as well, and people are really thanking you for this informative presentations. And they're kindly asking you to comment on the impact of advertising and media on obesity, because you alluded earlier when you come to the UAE and you saw Talabat, Deliveroo, and so many advertisements. So they are saying, mirroring the experience of the UK, how they were able to address the junk food and advertisement and the way that media try to sell junk food for the children. Do you have any ideas about how to mitigate that?
So I think, as you rightly point out, whilst I use those images of the Middle East, that could be anywhere on the planet. We all know the sort of ubiquitous nature of an unhealthy food environment and also an unhealthy physical activity environment as well. And we know that there are cultural influences, changes as well. So I think that we know that marketing and advertising is important, but what I would say is it's part of the mix. And I guess what I would say in the UK, and this is where my point about politics comes in, I would argue in the UK, we have spent a disproportionate amount of time focusing on advertising and marketing because from a political perspective, it's expedient. You don't actually have to do much other than deal with the lobbyists from the advertising companies. And you can be seen to be doing something, but the impact is relatively small. And I guess we've also got to be mindful as public health professionals that we don't know everything. And I've been working with colleagues, academic colleagues across the UK on a programme of work that has been looking at, in the UK, we have something called buy one, get one free. I don't know whether it's the same in the UAE, but so a couple of years ago, there was a lot of talk about government banning that in the UK. And it's going to be banned by law later this year. But a number of the supermarket companies implemented that action about 2 to 3 years ago. Now, some really interesting data has emerged. So a lot of the supermarket companies share their data now with the government, UK government, and a number of academic institutions. And Leeds University is doing some amazing work. What's called the Leeds Institute of Data Analytics. They're doing some amazing work, and they've done a lot of analysis of the impact of buy one, get one free and the change. So when a number of the supermarket companies implemented this change, it required a lot of effort on the part of the supermarkets to restructure where all their food was.
Yeah.
To most supermarkets, that was costing about £50 million a year to the operational changes. When they've evaluated the impact on purchasing, the change is negligible.
Mm-hmm. Mm-hmm.
So whilst we as professionals think that will have a dramatic impact, the only impact it's had is in loss to the supermarket companies. Now, that data has been validated by external agencies. So I don't think it's the supermarkets playing with the data. I think it's genuine, and it makes sense. Just because something's positioned somewhere, if we want a chocolate bar, we know where to go for the chocolate
We
bar.
get
And if
it,
we want 2 chocolate bars, we know we just reach for 2. So this premise, of course, marketing is important, but if we inflate its importance, public health professionals, and it diverts attention from other areas, I think we're going to do our profession in public health and our people a disservice.
Yeah, great. I'm really enjoying your answers, and it is really, we are actually reaching our minutes. So we'll have 1 minute. I would like to allude with the last questions. I think it's going to be an excellent wrap up to our discussion today from our director, Prof. Michael, is how can digital health interventions like mobile apps and social media campaigns, telehealth counseling, etc., can be leveraged to support children struggling with obesity, especially that it will provide non-stigmatized approach to mental health and well-being.
I mean, absolutely. So for the last 5 years, we've been working on the development of digital tools for children and young people, and we developed it on a big data back-end system. So we deal with about 30,000 people a year, 10,000 children. And what we are doing is behaviorally profiling and determining the psychology, the behaviors. We have wearables. So basically, we have a big back-end data system that encourages the app that our children and young people use. And a lot of this work was started as part of our program in Qatar with the QNRF, the Computing Research Centre in Qatar. So we have taken some real advances. And I think our ability to understand individuals and prescribe personalised support for them through mobile technology is going to be another game changer as we have with the GLP-1s.
Yeah, I agree. So again, I would like to apologize to all the audience. We thank them so much for their support and for their questions. And maybe you need to check, Prof. Paul, your email, because you're going to receive a lot of the questions from the audience because the discussion is actually growing and flowing. I would like really to thank you for today's webinar, for your insightful discussion. I will give the floor to Mariam to give a concluding remark. Thank you so much, Prof.
Thank you, Dr. Azhar and Dr. Paul, for accepting our invitation and delivering an outstanding and highly valuable presentation. I also wish to express my thanks to everyone involved in making this webinar possible, including the management of our college and UAE University. Special thanks are to Dr. Affet, Dr. Azhar, Mr. Ismail, Mr. Assajar, Mr. Amino, Ms. Bayan, Ms. Khadija Al-Blushi for their contributions and support. To our audience, thank you for your active participation. Kindly remember to fill out the evaluation in the link in the chat to receive your CME certificate. Stay connected with us on our IPH social media accounts at UAEU IPH as viewed on the screen. And you can access all webinar recording on our YouTube channel. We look forward to your participation in our upcoming webinar. Take care, stay safe, and